Dear Professor Liakopoulos, dear colleagues, good evening. In the next few minutes, we're going indeed to present Finerenone in kidney disease and especially in patients with type 2 diabetes mellitus. But first of all, I would like to start, sorry, here a problem.
We can see your slides.
Okay, thank you. But in the next few minutes, I would like to first of all to start with the importance of the prevalence of diabetes and its treatment. As in 2021, as you can see already in the slides, the global age standardized total diabetes prevalence was 6%. However, and despite the huge awareness from scientists and clinicians regarding the disease, regarding all the lifestyle changes we have to focus in order to lower the rates of diabetes mellitus with lifestyle, diet, physical activity. However, by 2050, we expect to have an increased, even greater age standardized rate of diabetes mellitus. And this is a huge problem if we take into account the complications of diabetes mellitus. And as you can see, the complications are both micro or microvascular, affecting the brain, the heart, the kidneys, but also small arteries such as from the eyes or neuropathy. Regarding the kidney, the blood flows, the excess blood flows overworks the kidneys, and as so, results in nephropathy. And things with the prevalence of diabetic kidney disease seems to be also dramatic, as type 2 diabetes is the leading cause of chronic kidney disease worldwide, and these two diseases are very closely related. As so, the international guidelines for the management of chronic kidney disease in patients with type 2 diabetes recommend the control of hyperglycemia in order to control and reduce the prevalence of chronic kidney disease, but also the control of hypertension. And also, they recommend to have a renin-angiotensin system blocker. It means that we can have either an angiotensin converting enzyme inhibitor or angiotensin receptor blocker. And more recently, they recommend also the use of a sodium glucose transporter 2 inhibitor. Nonetheless, and despite the recommended treatment, the risk of chronic kidney disease progression still remains, and thus so we need to have new therapies in order to lower this risk or the progression risk. And the new therapy regards the mineralocorticoid receptor antagonists and diabetic kidney disease. It was the first step to examine the effect of MR antagonists on diabetic kidney disease, and and we talk about the whole part of MR antagonists, both steroidal or non-steroidal. And you can see here all the pathophysiology mechanisms of MR antagonists, and you can see that blockading the MR means that we have a lower risk, a lower production of fibrotic mediators, such as the TGF-B or collagen, and we have a very good effect on reducing the oxidative DNA damage, or also reducing the pro-inflammatory mediators such as interleukin-6 or interleukin-1b or TNF-A. And all these are not the only effects of MR antagonists. You can see that also they have a good effect by reducing the vasoconstrictors such as angiotensin receptor 1, or by increasing the vasodilators such as the angiotensin receptor 2. Also, they have many clinical settings, and we talk about hypertension, diabetes, or chronic kidney disease fibrosis. And for these reasons, we can use as antihypertensive treatment, use them as an antihypertensive treatment, antiproteinuric treatment, or in order to prevent chronic kidney disease or to stop the progression of chronic kidney disease, and also to prevent the cardiovascular outcomes. And let's see the biggest meta-analysis at the field. It has taken all the MR antagonists, either steroidal or not, and they compared them in addition to ACE or ARB, and combine them with alone treatment with ACE and or ARB. As you can see, the results seems to be better when we talk about MR antagonists, the addition of MR antagonists. You can see that we have a lower difference, weighted mean difference in the first group regarding the GFR. And the results are impressive when we talk about the weighted mean difference regarding the urinary protein to albumin excretion rate. And you can see it's almost, the risk 30% less in the group of MR antagonists compared to the AC or ARB alone. So in total, we can see that they have a very good effect on kidneys, either regarding the change in creatinine, less and better results for MR antagonists, either talking about urinary ACR or 24-hour urinary albumin or protein excretion rate. And this is very important, but here we talk again about the whole aspect of MR antagonists. And it's not only the immediate effect on kidneys, but also the effect in other crucial points regarding the kidney damage. And we talk here about the blood pressure and hypertension. As you can see, when we add an MR antagonist to ASC or ARB, compared to the treatment alone, we have a better reduction to systolic blood pressure. The weighted mean difference was about 3 millimeter per mercury for the systolic blood pressure. So we have also effects not only immediate to the kidneys, but also to systolic blood pressure. But the problem is that when we combine these drugs, we have a threefold higher relative risk of withdrawing from the study due to hyperkalemia. And this is the main problem of this combination. And but the thing is that it's not it's not statistically significant the withdrawal of due to hyperkalemia when we talk about non-diabetic patients, but it is statistically significant, that you can see the risk ratio is almost 4% higher when we talk 4 times higher when we talk about diabetic mellitus patients. So exactly the patients that we need to add the MR antagonists. And let's go to analyze better finerenone. Finerenone is also MR antagonist, but a non-steroidal antagonist, and has a potent more anti-inflammatory and anti-fibrotic effects compared to steroidal MR antagonists. And as so, it might be a good option for our patients, for the patients who have also type 2 diabetes mellitus and chronic kidney disease. And let's analyze the randomized controlled trials regarding finerenone. First of all, you can see that we have a huge randomized control trial published on 2015 on JAMA Journal, and it was randomized double-blind placebo control. And in the first hand, we had in the first treatment that we had the oral once daily finerenone in any possible dose, 1.25 milligram till 25 milligram per day. And from the other hand, we had the matching placebo for 90 days. The patients were patients with type 2 diabetes mellitus and kidney damage. And when we talk about kidney damage, we talk about high or very high albuminuria. And the primary outcome was the ratio of the urinary albumin creating ratio at day 90. And as you can see, the results were better in the group of finerenone. But when we talk about doses more However, again, we had more discontinuation events when we talk about finerenone compared to the placebo group. However, the trial that the randomized control trial that make the most great impact on this point was the Fidelio DKD study. It was a randomized double-blind trial with more than 500 patients with CKD and type 2 diabetes, and receive either finerenone or placebo. The eligibility criteria were either urinary albumin ratio, creatine ratio of 30 to 300, and TGF more than 25 but less than 60, or a higher albumin to creatine ratio, 300 to 5,000, and GFR that it was always more than 5 but less than 75. All patients, either in the placebo group or in the finerenone, were receiving also RAS blockade in the maximum dose. The primary outcome was a kidney failure, a sustained decrease of at least 40% in eGFR from baseline, or death from any renal cause. And you can see here the results. The primary composite outcome was better for the group. A primary outcome event specifically was occurred in 70.8% in the finerenone group and 21.1% in the placebo group. And the result statistically significant. There was a statistically significant difference between these results. And also, we have a better secondary outcome occurred in finerenone group for 13% versus 14.8% for the placebo group. But here you can see better the outcomes. As you can see, the primary outcome was statistically significant compared to the two groups, and 20% less the risk ratio for finerenone, the hazard for finerenone compared to placebo group. Whereas for also when we talk about a decrease of more than 40% in the eGFR, again 20% less the possibility finerenone group compared to placebo group. But you can see that when we talk about the heart cardiovascular events, either death or non-fatal myocardial infarction or non-fatal stroke, hospitalization for heart failure, we do not, the two groups did not have any statistically significant trends. However, when regarding also the secondary kidney outcome, and that more than 60% in eGFR from baseline, again the results were better for the front group compared to placebo. So I think this is very clear that in kidneys it has a better effect compared to patients who are receiving only ARB or AC treatment. But again, the same problem with hyperkalemia. The incidence of hyperkalemia-related discontinuation of the trial was higher in the finerenone compared to the placebo group. You can see 2.3% for finerenone and 0.9% placebo group, and it's the only thing that it was our problem in this trial. Years later, the publication of Figaro DKD trial came to show also a very important outcome of the incident of heart failure. Again, in patients with chronic kidney disease and type 2 diabetes mellitus, but now we focused on a new onset heart failure. Indeed, the finerenone reduced statistically significant the new onset of heart failure compared to the placebo group, and especially all heart failure outcomes were statistically lower compared to placebo. 18% lower risk of chronic kidney disease death or first hospitalization for heart failure, 29% lower risk of first hospitalization of heart failure alone, and 30% lower rate of total hospitalization heart failure in the group of finerenone compared to placebo. And I think these results are impressive and showing the importance of finerenone in these patients. And here you can see the results of fidelity study. In the fidelity study, they took the results of the previous the two previous published studies, and examined the total of patients. And you can see here we have two figures. The first one is regarding the baseline, regarding the cardiovascular disease death based on eGFR and UACR less than 300. In the second figure, we have the first hospitalization for heart failure risk regarding again the baseline and the baseline GFR and the baseline UACR when it was more than 300. And you can see that the lowest incidence that were seen in patients with eGFR more than 60 and UACR less than 300. However, Finerenone improved the heart failure outcomes irrespective of baseline eGFR and or UACR categories, either talking about cardiovascular death or first hospitalization for heart failure. And based to these big studies, Fidelio DKD and the Figaro DKD, cardiovascular outcomes, the FDA and EMA approved Finerenone, first of all, due to Fidelio DKD trial in 2021 for the treatment of chronic kidney disease in stages 3 and 4 with albuminuria in patients with type 2 diabetes. And after that, due to the results of Figaro, in 2022, FDA and in 2023, EMA approved also the Finerenone in early stages of chronic kidney disease in patients with type 2 diabetes mellitus. And as so, guidelines have changed regarding this special category, diabetic kidney disease. You can see, first of all, the ADA guidelines in 2024. They talk about a treatment of SGLT2 in patients with type 2 diabetes mellitus and chronic kidney disease or GLP-1 or non-steroidal MR antagonists if the GFR of our patients is more than or equal to 25. However, when we talk about people with chronic kidney disease and albuminuria, as they are at an increased risk of cardiovascular events or cardiovascular disease progression, they recommend that we can use the non-steroidal MR antagonist in order to reduce the cardiovascular events and the progression of chronic kidney disease. Also, the guidelines of hypertension of the European Society of Hypertension talk about the use of Finerenone in patients with chronic kidney disease due to diabetes and moderate or severe albuminuria due to their both nephroprotective and cardioprotective properties. I think the results are very clear. We have to focus on Finerenone when we have patients with both chronic kidney disease in early stages, even in early stages, and diabetes mellitus, in order to lower both the progression of chronic kidney disease and the cardio metabolic effects. Thank you very much for your attention.